better.
All right, I'll do it on my computer. I got it. Okay, we're
Okay,
recording.
good. Okay, so just make sure you're inviting the people, because I saw two and I invited myself here. It's a work. It's a full-time job. So there's a change in the immune system and understanding the immune system. Before we learned that we have only two kind of T lymphocytes, which is Th1 and Th2. Th2 involved in the humoral immunity. Th1 is for cytotoxic immunity. That's what we learn when we are in the medical school. And we know, yeah, there is two kind of CD4 positive T cells and the CD8. The CD8 are the cytotoxic T cells. The CD4 are the T helper cells. So all the T helper cells, they are CD4 cells. And they do play an important and critical role in regulation of the human health and diseases. Yes, and that's why we're going to learn that language by orchestrating the immune system against a foreign antigen such as infection and cancer. All right. And so before the 1980s, helper T cells were believed to be the single subset among the T lymphocytes. But now we know there is T helper, and T cytotoxics, and the T helper, before they thought there's only two subsets, which is Th1, which mediate still mediate immunity through the cytotoxic T cells, and Th2, which mediate the humoral immunity, which actually making those antibodies, right? So increasing evidence now suggests that there are at least 4 distinct T helper subsets differentiate in response to particular combination of cytokines. Today we're going to learn those subsets: Th1, Th2, and 2 T lymphocyte that we learned that maybe differentiate or distinguish itself from the Th1 is Th17. And we have the Th-reg, which is very important to suppress the immune system. They suppress all those effectors: Th1, Th2, and Th17. So how we develop Th1 lymphocytes? It starts from the macrophages, or those antigen-presenting cells, right? And they're the one who determine which direction those naive T cells will move to, or become, or develop, polarize. So let's start. If the macrophage ate infected cell with viruses, or ate cancer cells, so you think about the macrophage is eating cancer cells, or virally infected cells, what would happen to this macrophage?
17?
They start as a naive macrophage. They polarize into M1.
Over than 17.
And they start secreting interleukin 12. And that will determine which direction your T lymphocytes, T helper lymphocytes will go to. They will develop and polarize into Th1. So the macrophages and what the macrophage eats determine what direction the naive Th cells will take, what destination. If the macrophage ate cancer cells, virally infected cells, and they start secreting interleukin 12, then the naive T cells will polarize, will develop, and become Th1. So in interleukin 12 influence the Th1 cell development and promote immunity in the presence of interferon gamma, right? And so what will happen, those Th1, they start secreting interferon gamma. Interferon gamma will positively activate more of the macrophages and make those macrophages polarize into M1. So you will have a polarization of the naive macrophages or antigen-presenting cells or dendritic cells to become DC1, M1, antigen-presenting cells 1. At the same time, we'll see the lymphocytes is moving to that direction, which is Th1. And the T lymphocytes, which is Th1, secretes interferon gamma, which actually have a positive feedback, stimulating more polarization of macrophages to become M1. So you have that positive feedback between Th1, M1, and they are activating each other. Ultimately, the whole goal here is to kill the infected cells with virus or cancers by stimulating cytotoxic T cells, right? Which is CD8 T cells. They are the one who will do the job. They are the soldiers that they will attack those infected cells of viruses, infected cells, or cancer, and cause the destruction by secreting their cytotoxic chemicals that will open up pores into the cancer cell membrane and into the infected viruses and kill those foreign bodies or foreign cancers and infected cells. So now we know the direction here is all depend on what the macrophage eats. If they eat cancer, whole cell cancer, or they eat infected cells with virus, they polarize into M1, and then M1 polarize the naive T cells into T1. And they start secreting interferon gamma. So what about the Th2, right? We know the Th2 responsible for the humoral immunity, yes, especially the allergic reactions and the attack against the parasites. So what happened, or how Th2 emerge or differentiate or polarize from the naive T cells? It depends on the macrophages. The macrophage will determine exactly the polarizations of those naive T cells. If the macrophage ate engulf parasites, right, antigens of the parasites, let's say a patient has a worm in his stomach and the macrophages are eating the antigen that's being released from this worm, or the macrophages are eating allergens. Let's say, for example, you have pollens and the macrophage ate pollens. What will happen to this macrophages, naive macrophages or naive dendritic cells? They polarize and become what? M2, DC2. And they start secreting interleukin-4. Interleukin-4 responsible to polarize naive T cells into Th2, right? And then the Th2, they start secreting interleukin-4, interleukin-5, interleukin-13, which activate the B lymphocytes. And the B lymphocytes, they start producing what? Plasma cells, and plasma cells start producing antibodies. And that's how we have this humoral immunity. And you will see that those antibodies are immunoglobulin E, which is very important to destroy the parasites, right? And eliminate the parasites. Through immunoglobulin E activated basophil and mast cells and eosinophils, right? So when we do the CBC and we see that we have high eosinophil and basophil, then we think that the immune system is being polarized into Th2, M2. Just by looking through the CBC. If you see that in your CBC that your eosinophil and basophil is high, that's mean you may have allergies or you may have a parasite infection. And so you need to come up with more investigations to find out if this is allergy or parasite. And we also know from here that the immune system is moving to M2, Th2. Okay. This is the new subset or type of T helper lymphocytes. It's being recognized just recently. I believe when we are in the medical school, we have no clue that there is something called Th17. And how Th17 developed, Of course, it's all depending on what macrophage eats. If the macrophage eats extracellular pathogens, such as bacteria or fungus, or even free viral antigen, not the one the virus be infecting the cells, not the cells as being infected with virus, but free debris of the antigens of the viral or free debris of the cancer that's free floating, not the one that's the whole cell of cancer, but if they eat just the debris of the antigen, then they polarize into macrophage dendritic cells type 17. And then they start secreting what we call the interleukin, the interleukin 17, right? So those macrophages, they start secreting interleukin 6 first and transforming growth factors. And what would happen when you have a macrophage that is polarized into M17 or then DC17, they start secreting what we call a transforming growth factor and transforming growth factor beta interleukin 6. And these two factors will polarize your T lymphocytes into TH17, and the TH17 will start secreting interleukin 17. Interleukin 17 will positively feedback and stimulate polarization of the macrophage into M17 and DC17, right? It's a positive feedback there. Okay, and what exactly the function of this subset? Why we have TH17 and M17 is that this helps to stimulate the innate immune system. It helps to recruit the neutrophil, activate the neutrophil to attack the foreign cancer or infection, especially bacteria or fungus. And what will happen in the CBC, you will see that we have high neutrophil. So when you do CBC differentiation, you will see high neutrophil, right? And so when you have high neutrophil, you may consider the patient has infection with bacteria or fungus first. But as you know, that in COVID-19, and this virus is very tricky, was able to hijack the innate immune response and make it look like you are being attacked by bacteria. And the reason we will see that in those patients, they have high neutrophil. This is very smart of the virus of COVID-19. How that happened, this virus blocks the ACE2 receptor, which blocks the anti-inflammatory arm of the RAS system, allowing the inflammatory arm, which is signaled by angiotensin 1 receptor, to be active. And when the angiotensin 1 signal is being active, the downstream of that signaling leads to polarization into TH17 and M17. So the virus is fooling the immune system and is making the immune system that they are being attacked by bacteria in a state of being attacked by the virus. So this is something we need to consider that and understand how this virus is persuading the immune system and is trying to push it from supposedly the best way of really attacking this virus, especially the cell that's being infected with the virus. I'm not talking about the free floating viruses, but I'm talking about the infected intracellular virus. The best way of responding is to be that the immune system polarized into TH1, M1. So you have enough of cytotoxic T cells to kill those infected virus. But this virus knows about that, seems like, and they are pushing the immune system to TH17, causing what we call cytokine storm, which is really an immune that we don't need. We don't need really much of TH17. We really need to TH1 to attack, to destroy those infected viruses. And that's why when we treat COVID-19, we are giving treatment that will polarize the naive T cells into TH1, right? And that's why we give them losartan, for example. That will help to inhibit the Th17 signaling and polarization and move it to Th1 so we can destroy those infected cells with this virus. The other thing about Th17, the good function about Th17, especially if it's being the response is normal response, not aggravated response. If you have too much of Th17, it may cause damage in the gut barrier. But in a normal response, they are the one who are responsible to form the barrier on the gut or connect the barrier and prevent the leakage of the toxins of the bacteria through the gut. We call the leaky gut syndrome. Okay, so they secrete chemicals, especially interleukin 22, that helps to heal the gut. We need that, right? And also because they are recruiting neutrophils, and then neutrophils helps to kill all those bad bugs, bad germs, that a bad microbiome or bad germs in the microbiome that we don't need to be there. But if you do have an overactive Th17, it's possible that can lead to the opposite. It can destroy the barrier because too much of neutrophil can cause inflammation that destroy the barrier and lead to leaky gut syndrome. So you have to have a proper response there. But Th17 and a normal response is very important to keep the integrity of the gut and prevent leaky gut syndrome. Okay. Then we have another form of lymphocytes. It's called T regulatory. They are the police who controls the effectors, the Th1, Th17, and the Th2. We call them those effectors. They suppress them, preventing them from going beyond the norm. So you need to have some control there, right? The police, Treg. And how that happened, how it developed, and what's its function. When the macrophage and the dendritic cells, the naive ones, when they eat your own antigens, self-antigen, whether it's part of the cells or free-floating, what will happen? They start polarizing into macrophage regs and DC regs, and they start secreting interleukin 2 and transforming growth factor beta. Both of those factors or cytokines would definitely influence the polarization of the T lymphocytes into Treg, and then the Treg starts secreting interleukin 10 and transforming growth factor beta, which positively feedback and increase the polarization of macrophage into M-reg and DC-reg. So it's kind of positive feedback each other, moving the immune system to that direction. And this is very important because this will help to suppress the immune system from eating your own antigen. So it prevents autoimmunity. So Treg is very important because it does help to prevent our immune system from attacking our self-antigen. By secreting all those chemicals, interleukin 10, which will inhibit any effector out there, effector T cells, which is whether it's Th1 or Th17 or Th2 that will attack your own self-antigen. This goes to suppression and regulation, preventing the autoimmunity from happening. Okay, so now we learned the alphabet of the immune system and how it operates. This is very important language. Without this language, we have no clue how to modulate the immune system, what's good and what's bad. Without understanding of the immune polarization and modulation and how they operate, we cannot really guess whether thymosin alpha or thymosin beta is good for this specific patient. So knowing how the immune system works, it is very important because this will help us to manage chronic diseases in general, especially the autoimmune diseases, but also cancers as well. Okay. So we need to understand that when we are moving to one direction, let's say the macrophages is now eating viruses, infected cells with viruses, or eating cancers. So what will be the direction will be Th1, M1, right? And they are going to be positively feedback each other in a way, each one stimulate the other. So the interferon gamma, interleukin 12, right? Okay. But also those cytokines of the Th1 and M1, they will be inhibiting all other subsets. They will inhibit the Treg, they will inhibit the Th17 and Th2, making your immune system moving to that one direction. And so we would have something we call equilibrium here, right? Okay. So up activation of one particular subset, other subsets are modulated or inhibited in order to promote the most specific effective response in defense against the imminent threat. So in case of COVID-19, what I really want more of Th1 M1, so I can kill those infected, those virus that's being hidden inside those cells, or those bacteria that's being hidden inside the cells, or those cancers, this intracellular pathogens. That's what I want. I don't want to go much of Th17. I need some, but not much, maybe to get rid from any free viruses out there. But I need more because those viruses, mainly they are living inside the cells, they don't really proliferate outside. And so, and I can neutralize them using antibody Th2. So you get some response of Th2, but most of my need is Th1. But this virus, because it's altering and hijacking the RAS system, is actually causing the immune system to move to Th17. And that's the reason why this virus is very virulent, right? But in general term, if you've been infected with, if you have cancer infection, even when you do the CBC, you will see high lymphocytes, right? When you have a bacteria infection or fungus, then what you will see, you'll see the Th17 is high, interleukin 17 is high in the blood, right? Because that's responsible for the neutrophil. So when you see neutrophil is high, then you think the Th17 is working. And those the factors, the cytokines released from Th17 and M17, they will be inhibiting all other subsets, moving to that direction so you can kill efficiency, you can kill those bacteria and fungus because they are specialized to do that. If you have a parasites and you check the CBC, you will see that the eosinophil mastophil is high, right? And that's what we need in this. And that's mean you have what? Th2, M2 is active. And the cytokines of Th2 and M2 inhibits other lymphocytes. So it keeps the immune system moving to Th2. Before, when we trying to manage allergies because of this concept, and when I was doing some research in beta, trying to treat allergies from peanuts, and they moved the immune system where when you have allergy to peanuts, your immune system will move to Th2, right? And you have mast cells and basophil high. So one of the ways that we're going to treat them is trying to move and polarize the immune system from Th2 to Th1, shifting it. And what we do, how we do it, we then desensitize or polarize the immune system back to Th1 by developing a plasmid of bacteria that express the antigen of the peanuts, right? And what I was doing at that time in Baylor College, I was loading that inside the red blood cells. So the red blood cells eventually will be carrying those genes into the dendritic cells. And when it's being carried as a gene inside the cells, your immune system will be polarizing to Th1 because anything that's intracellular pathogens or intracellular expressed antigen, your immune system will recognize it, or your macrophage will recognize it as an M1, and it will polarize into M1, and then this will polarize your immune system to Th1. And then the cytokines of the Th1 will inhibit the Th2, which will treat allergies, right? If you do that, you treat allergies. Those interferon gamma is being released with this treatment. It will inhibit the Th2. cytokines, and that will treat the allergy. Same thing if you're trying to treat cancer. What I want in cancer, I want to kill the cancer, so I'll polarize the immune system to Th1, right? To M1. And now they are developing cancer antigens inside plasmids or inside RNAs, and then they nanoparticulate it using phospholipid bilayer or platelet-derived exosomes, and they inject it into the body. It gets into the macrophage. Macrophage eats them and starts expressing those tumor antigens, but it's a good thing because it will eventually move the immune system to Th1, and that's what we need because Th1 will stimulate the cytotoxic T cells, and that helps us to kill the cancer. We call this cancer vaccine. So when we are in the medical school, myself, I know Th1, Th2, and the shifting of Th1 and Th2 and how to modulate that. And we know that the cytokines of Th1 inhibits the Th2, and the cytokines, which is interleukin-4, inhibits the Th1. So I use this to manage cancer and allergies and viral infection, right, by polarizing those immune systems. And before we know that the Th1 is responsible for cell-mediated immunity, right, which is the delayed type hypersensitivity reaction. We know that the Th2 is responsible for humoral immunity and also responsible if they are abnormally activated, they will lead to allergies, right? So the early studies claim that Th1 still mediate tissue damage, right, in delayed type hypersensitivity by cytotoxic T cells. That's right. And they are the ones responsible for tissue damage. That's what we learned before. We have no clue that there is Th17 at that time or Treg. But when we start learning that there is something else beside Th1 and Th2, when we start trying to treat a lab that we can induce in the rats, sort of MS, it's an equivalent of an MS. It's called the murine experimental autoimmune encephalitis. It's an MS of the lab. Okay, so they give the rat some toxins to stimulate the immune system to attack the myelin sheath, to simulate the MS. And in our mind, that MS is caused by Th1 hyperactivities, where your Th1 is killing your own myelin sheath, your own antigen, right? So there's abnormality in the Tregs and overactivity of Th1. That's what we thought. And then we thought, okay, if it's all about Th1 and M1, that's mean the cytokines here is interferon gamma and interleukin-12. So let's do this. Let's go ahead and block the interferon gamma, and we can treat those patients or those and alleviate the inflammation. So they did that. And what happened is that it made the immune reaction even more worse. So now we start thinking, well, why is that? And they find out when you block the interferon gamma, which is very important, interferon gamma, because it blocks a Th17. And we find out that MS and this experimented autoimmune encephalitis, it's not just Th1 is active, but also Th17. And when we block the interferon gamma, what happened? You will have too much of Th17 overactive, and that caused neutrophil recruitment of neutrophil and natural killer cells and destruction of the myelin sheath. So this is how we learned that there's another subtype, which before we thought is part of Th1. It's called Th17. And yes, the Th1 cytokines inhibit the Th17, and the Th17 cytokines inhibit the Th1. And so there is a balance between Th1 and Th17, recognized that interferon gamma interleukin-7 has antagonistic properties. Means that Th1, they secrete interferon gamma, it does inhibit the Th17 development, and Th17, when they secrete interleukin 17, it inhibits Th1. So finally, we know that there is antagonistic relationship between Th17 and Th1, and also we also find out that there is antagonistic relationship between Th17 and Treg as well. What does that mean? The cytokines released from the Treg, which is interleukin 10, inhibits the Th17, and that's very important to calm the immune system, right? Preventing from the autoimmunity. And the Th17 does inhibit the Treg. And they do have similar cytokines. What is the similarity? The common cytokines between Th17 and Treg is transforming growth factor beta. But really what makes it moves either to Th17 or Treg is the interleukin 6 and interleukin 10. So if you have high interleukin 6, it moves things into Th17. If you have high level of interleukin 10, it moves the immune system to Treg, right? And we know that Tregs, cytokine, especially interleukin 10, does inhibit the Th17. So there's a balance there, right? And we need that balance. We need a Treg to be active to prevent self-destruction from those effector cells, which is the Th17, Th1, and Th2. Okay, there is more information here. Biology is not fixed rule. There must be exceptions. There must be if and buts, right? This is what we learn in medicine. Nothing is like, okay, is all the time that the Th1 inhibit the Th17? Is all the time Th17 inhibit the Th1? Is this fixed theory? No, there's some plasticity there, or flexibility there. And what is that? Okay, let's think about multiple sclerosis. We know the multiple sclerosis is due to both, really. It's Th1 and Th17, but how the Th1 and Th17 coexist at the same time where they are inhibiting each other. Yes, they are fighting and inhibiting each other, that's true. And because of this inhibition effect, Th17 can evolve and transform, we can say, through a plasticity, and they act like Th1, and they stop producing interleukin 17, which inhibits the Th1, right? And they start producing interferon gamma. And not just that, they also start secreting what we call the granulocyte, monocytes, colony stimulating factors, which will recruit more of white blood cells. And what should we call this Th17 when they look like Th1 because they start secreting interferon gamma and stop secreting interleukin 17? We call those X-Th17. And they are the really pathogenic cells that leads to the progression of the multiple sclerosis. And the reason why, because they are out of control, because Treg cannot really inhibit effectively those X-Th17, that they act like and behave like Th1. That's the problem we have with multiple sclerosis. So they are out of control. See, Th1, the classical Th1, can be inhibited by Treg, by interleukin 10, right? They secrete interleukin 10 and say, hey, Th1, calm down. And how they do that, they induce what we call the senses, the aging, and they become aged and they die, induce apoptosis. But Treg cannot control this new phenotype, this new emerging X-Th17, and I think it's responsible for the pathology or pathogenesis of the MS. That's one of the problem we have when you have the flare-ups. Think about X-Th17. Those Th17, they become acting like Th1, that out of control, that Treg cannot suppress them. So Th17 cells can acquire Th1-like characteristics after activation, a property that likely play a role in enhancing autoimmunity and anti-tumor immunity. So it's good that, you know, we can use this to kill cancer, but it's bad when it's in autoimmune disease, because it makes the autoimmune disease hard to treat. These cells lost their ability to secrete interleukin-17 while gaining the capacity to secrete interferon gamma. They act like Th1, but really they are Th17 turned into Th1 in the presence of pro-inflammatory signals such as exposure of interleukin-12. So we know that multiple sclerosis, yes, it's Th1 dominant. Yes, they have too much of interleukin-12, but also there is some Th17 activities there. And what happened is that those Th17, they act or evolve into XTH17 under the influence of the interleukin-12. And they can be still distinguished from the classical Th1 cell via unique surface markers, including the CD161, CCRS, and interleukin-17RE. I don't like to bring all those genetics because it's for clinical, not that important for us. What's important is to know those general things that we can use when we are creating protocols. Moreover, the cells are functionally distinct from classic Th1 cells. Right, they are more wide, hard to control, and also they secrete more cytokines. They secrete tumor necrotic factor, interleukin-10, but what's importantly, they secrete granulocyte, monocyte colony stimulating factor, right? And this will make the autoimmune more worse because it will start recruiting all those neutrophil and basophil into the area of the autoimmune lesions and cause the flare-ups. But this is good for cancer. If I want to treat cancer, I think I will try to shift the Th17 into Th17 because that will increase the white blood cells in the fight against cancer. So this is something we need to use it in our advantage in destroying cancer. But I think it's a bad thing when it comes into autoimmune disease. So interestingly, the proliferation of Th17 cell is not suppressed by the Treg cells, which is good for cancer when we treat cancer, but it's not good for autoimmune disease because it makes it hard to treat it. Treg cells cannot control them, which is in contrast to the Th1. Th1 can be inhibited by interleukin-10. Th17, they can't. And this data implicate a possible role of the cells in and balanced Th17 reg autoimmune response, right? Where you would have those Th17 rebellions and they are not being controlled by the reg. And that is really the pathogenic of this multiple sclerosis because of those cells. This absorbed plasticity of Th17 occurs only in direction of Th17, right? So but not the Th1. So we don't see that Th1 turn into Th17. We don't have that. We only have Th17 becoming Th1, okay? Up to now, we did not learn that from all the disease that we have, or we don't have that reverse of the Th1 to Th17, but we have the Th17 can evolve and become rebellion, X to Th17, and they act like Th1, but they're not originally a Th1. Okay. Again, in biology, it's all, there's exceptions. So they're not all the time antagonizing. Sometimes when they antagonizing itself, they change to the other side, right? As we saw here, we know Th17 and Th1, they're fighting and antagonizing each other until the Th17 decide to behave and act like Th1. And if that's the case, and they're not producing any more interleukin-17, in fact, they're producing interferon gamma, means interferon gamma, which is coming from Th1, makes it's good for those Th17, right? The same thing happened in Th17 Treg. What will happen? The Treg can evolve and become Th17. And that's bad news for autoimmune diseases. when you see the Treg is becoming Th17, that's mean more inflammation, less control, right? Think about, make it easy for you. Think about the police is becoming a criminal. Think about Th17 as a criminal, right? Attacking your body and destroying, like the riot that's happening in DC, right? And think about the police in a state of control and preventing that riots. They are part of the riots. And we saw that. We saw some soldiers there, right? In the riots. And that's not good, right? So this just gives you some way of imagining things. So Tregs are able to acquire characteristics of Th17 cells under cytokine-driven inflammation. So if you have too much Th17 secreting interleukin 17, and we know there's a fight between interleukin 10 and interleukin 17, but too much of interleukin 17 and interleukin 6, interleukin 17 and which is interleukin 10, yes, but there will be a fight there. But if you have too much of interleukin 16, it is possible that it will push the whole thing from Treg into Th17, and they become an X Treg, right? Acting like Th17. X police acting like a criminal, attacking and destroying the body. So when they're exposed to too much of interleukin 6, which is coming from the Th lymphocytes, right? We know that that's how they push. We know the Treg, both they have common cytokine, which is transforming growth factor beta. But what moves it to Treg versus Th17 is interleukin 6 versus interleukin 10. Interleukin 10 moves it to Treg, interleukin 6 moves it to Th17. But if you have too much of interleukin 6, it may turn those police, those Tregs, and becoming like acting like a Th17, and they start secreting Th17 interleukins and interleukin 6 and act like Th17. And then you will decrease the immune tolerance, you will aggravate, and you will have more flare-ups of the immune system. That's not something good, right? And so they will be expressing interleukin 17, interleukin 22, interleukin 23, which is the things that interleukin 17 T cells are producing. And this X-Tregs have been implicated in pathogenesis of autoimmune arthritis, right? Where your immune system is attacking your own self-antigens. And the police, the Treg is not controlling because they become criminals. They become Th17, recruiting neutrophils, granulocytes, and destroying your joint. And this will definitely lead to reduced ability to suppress cytotoxic CD8, which is coming from the T lymphocyte Th1. If you have less of Tregs and less of interleukin 10, then you will have, unchecked Th1 and Th17, and unchecked Th1 will start stimulating CD8, cytotoxic T cells, which will start destroying your own arthritic joints or your own cartilage, along with the neutrophils that's being recruited by the cytokines of Th17 and 17. And this leads to what? Autoimmune diseases. And so the lack of Treg, the lack of the police, and police becoming criminals, becoming Th17, it's a problem. It can lead to legal autoimmune immunity in humans. So the altered homeostasis between Th17 and Treg has been implicated in several autoimmune diseases, including multiple sclerosis, psoriasis, rheumatoid arthritis, inflammatory bowel diseases, and systemic lupus erythematosus, where the Tregs, in a state of secreting interleukin 10, they become Th17, they become criminals, vector cells, in state of suppressor cells, and they start stimulating destruction and autoimmune reaction and involved in the pathogenesis of all those chronic autoimmune or inflammatory diseases. Okay, so we learned the alphabet. Now we're gonna go to the case. If I have a case of multiple sclerosis, what happened in multiple sclerosis? What's the pathogenesis? Because if we know the pathogenesis, we can figure out the protocols and how to manage it. Whether I'm in multiple sclerosis, which is better, giving interferon gamma, transforming peptide thymosin beta or alpha? How thymosin beta works, how thymosin alpha works, is if the thymosin alpha is polarizing to Th1, I really need less of it. But we know also thymosin alpha stimulates the Treg, which is a good thing about thymosin alpha. And it stimulates the neurogenesis. So you may consider that. But I like to give thymosin beta, because thymosin beta do inhibit the Th17 and also do inhibit the Th1 and stimulate the Treg. So that's a good thing, because that's what's happening in multiple sclerosis. What we have less active Treg. The police are not active. They transform into Th17, right? And then I have too much of Th17, and some of them they transform into Th1, become X Th17, and then I have overactive of Th1. And we know that Th1 is overactive. That means we have a lot of cytotoxic T cells that destroying the myelin sheaths. I have a lot of neutrophils, right? Because of the Th17 is activating them, stimulating, secreting those colony stimulating factors, granulocytes and monocytes. And of course, if you have too much of those inflammatory cytokines, it definitely can affect the brain barrier and makes it leaky, right? It leads to gliosis. It also can affect your gut barrier as well, right? And it leads to leaky gut syndrome. And one of the mechanisms is that if you have too much inflammation in the brain, this leads to sympathetic overactivities. Too much inflammation, too much of free radicals, less nitric oxide. Nitric oxide responsible to suppress the sympathetic tone and stimulate the vagus, the parasympathetic tone. So what will happen here, because you have too much of inflammation, less of nitric oxide, there is no break on the sympathetic become overactive. So what will happen when you have sympathetic overactive? Going to the gut, sympathetic release norepinephrine. Norepinephrine stimulates the NOx enzyme. NOx enzymes generate free radicals. Free radicals cause more inflammation in the gut, right? Overactive Th17 in the gut. Think about that. Too much of neutrophils. And that leads to destruction of the barrier. Leads to leakage of the toxins from the gut, the bacteria toxins from the guts, which is the polysaccharides. Where those polysaccharides and toxins goes from the gut into the blood, right? And then into the brain. And when you have too much of those toxins, which are free radical generator, they will aggravate the whole inflammation. They will aggravate the gliosis. They will aggravate the inflammation that's destroying the myelin sheath. And then you have this vicious circle. Okay, then more sympathetic tone, more leaky gut, more toxin in the blood, more gliosis, more inflammation of the brain, and you have this vicious circle of destroying the brain. So multiple sclerosis is a chronic inflammatory disease involving destruction of myelin in central nervous system, white matter. That's what we know, right? Because you have the Th1, Th17, overactive, destroying and recruiting all those white blood cells. Where the cytotoxic T cells and neutrophils, they are destroying the myelin sheaths. This disease presents in patient as a deficient in sensory and motor, both, right? Myelin sheath, especially those fast conductive neurons. And it leads to unilateral vision loss, diplopia, because weakness of the neurons of that moves the eyes, right? It leads to damage of the myelin sheath centrally, central nervous system, not the peripheral, central. So it leads to gait disturbance, loss of blood bladder control, right? Among other various symptoms of the nervous system malfunction. And we know about multiple sclerosis. It leads to what we call the upper neuron lesion symptoms, whether it's sensory or motor, but it's upper, not the lower. So they don't attack the Schwann cells of the peripheral neurons, they attack the oligodendrocytes of the that wraps the central neurons, whether it's motor or sensory. And so we understand that multiple sclerosis is a disease and that involves overactivity of Th17 and Th1. Th17 eventually can evolve and become Th1 when they're starting fighting each other, and they become X Th17, which is more worse because they cannot be controlled by Tregs, right? And not just that, if the inflammation is too worse, then the fight between the Treg will give up from fighting Th17 and they become Th17. Those police, those regs, they become and they cause destruction. So this data suggests this Th17 cells are pathogenic, especially the X Th17, due to their ability to co-secrete multiple cytokines. We know that when those Th17 become acting like interleukin Th1, they secrete now things that Th1 secretes, which is interferon gamma, but also they secrete that what Th17 secretes, which is colony stimulating factor, recruiting all those white blood cells to the site of the lesion, make it even more worse. And then it's just hard for the Treg to control them because they act abnormal. Okay, so this is just a picture. The diagram here shows that, you know, we have three cells involved here in multiple sclerosis: interferon gamma, Th1, and Th17 and Tregs. And we know the Th1, the cytokines of Th1 is interleukin 12 and interferon gamma. And the Th17, we know it's interleukin 6 and transforming growth factor beta. And Treg is transforming growth factor beta and interleukin 2. But what makes it move, which direction, it depends on the level of interleukin 6. If you have too much interleukin 6, it moves things more to Th17. You see, the common cytokines is transforming growth factor beta, but what determines which direction will move? It's actually the interleukin 6 level and also interleukin 10, but mainly interleukin 6. So the ratio between interleukin 6 and 10 determines which direction to move. If you have too much of interleukin 6, it definitely will move the whole thing into Th17. And if you have all this too much of inflammation and those Th17 secreting too much of interleukin 17, they can definitely transform the Treg so they can behave or become behaving like Th17, and they give up secreting interleukin 10 and they start secreting interleukin 17, right? And this is the bad thing when your police become criminals. So interleukin 17 level have been reported to be increased in the cerebrospinal fluid of the multiple sclerotic patients during the symptomatic relapse, as well as in the chronic lesions. We find out that they have too much of interleukin 17, both upregulation of interleukin 17 and interleukin 12, downregulation of Treg mediated immunity, interleukin 10, likely contribute to the pathogenesis of multiple sclerosis in humans, perhaps targeting a combination of both. What we need to do, we need to suppress the Th17 cytokines and Th1 cytokines and increase the cytokines of the Treg in order to manage multiple sclerosis. So now we know the pathogenesis. Now we know how to manage multiple sclerosis. So we need all the treatment that will block the Th17 cytokines and the Th1 cytokines like interferon gamma blockers or interleukin 12 blockers, which block the Th1. And also we need to block the Th17 using blockers that we have as like Big Pharma. They have this antibodies where they block the receptors of those cytokines. Are they good? Well, the problem with those, we call them biologics of the Big Pharma.
Are you?
They do have side effects. That's the problem. When you block something and you start modulating the immune system, it may interfere with their function on other side. Like if you suppress the immune system here, you may put the patient vulnerable to infection and cancer. So that's the problem we have with Big Pharma. But is there any integrative, natural way using less or drugs that has less side effects? Yes, and we're going to talk about them. So how we can treat autoimmunity is by blunting the Th1 and Th17 cytokines, right? Which is the interleukin 12, interleukin 17. If we find a way to
block them, yes, we do have antibodies. We have blockers for that, right? They're FDA approved. Which one is called for the interleukin 17,
secukinumab, and then we have the
kinumab, which blocks the interleukin 12. So those are antibodies. We call them biologics. They are cytokine blockers. When the patient has a flare-up, yeah, I will use them. But if I can put them in a nanoparticle, like put them inside platelet-derived exosomes, I may minimize the side effects. So that those cytokines will not go all over the body. They will go into the lesion only. So this is very important of nanotechnology, to minimize the side effects of this big pharma. Think about if you give those blockers freely into the blood, and it goes everywhere, healthy and pathology, then yes, you will benefit from the pathology for suppressing the immune system. That's the multiple sclerosis in the brain. You need that. But in other organs, you may end up compromising the immune system and leading to those side effects, right? Leading to emerging of infection and cancer. And it can also affect the leaky gut syndrome, right? Or it affects the guts. It goes the more leaky, and that may aggravate the whole condition. So that's the problem with big pharma products. One of the problems is that they do have side effects from interfering with the physiology, the good thing. Yes, we need to suppress the immune system in the brain, but we don't want to suppress the immune system in the gut or in the lung and risk the patients having pneumonia and infection. But I think the best way of minimizing the side effects of those big pharma products, if we use nanotechnology, the nanotechnology which wrap them inside a phospholipid or PSGA or the best of the best, which this is something that I'm doing right now. A lot of clinics that I have are adapting those. That can be done in the clinical level. You don't need to spend billions of dollars to convert those drugs into nano. You can do it in your clinic. Just use platelets. Platelet, mix it with cytokines, break them down with sonication, nanofilter it, and here we go. We got a nano autologous exosome, loading those exosomes, loading those cytokines, and they will deliver it mainly into the pathology. Why? Because the pathology is more leaky. Healthy tissue, their blood vessels are less leaky, and those nanovesicles, they tend to leak into the pathology, into those leaky blood vessels, right? And that will spare the healthy tissue from getting those harmful cytokines, allowing those cytokines to go to the pathology, which we need them to suppress the immune system. Okay. The other thing about Th17 blockers and how I can block the Th17 and maturation of the lymphocytes of Th17, we can use losartan. Remember we talked about that the RAS system, if it's being unchecked by blocking the anti-inflammatory arm, which is the ACE2 and angiotensin 2 receptor signaling, right? That's that anti-inflammatory in the mass. To talk about interleukin, so if we block that, that's what's happening in COVID-19, right? What will happen? You would have unchecked what we call it, angiotensin 1 receptor. And when you haven't checked angiotensin 1 receptor, which is the inflammatory arm of our RAS system, this signaling, the down signaling, leads to polarization of the T lymphocytes into Th17 and secreting of a lot of interleukin 17 and interleukin 6, which will recruit a lot of neutrophils, which will lead to destruction of the lung and lead to fibrosis, right? So Th17 overactivities can lead to fibrosis. And so now we understand that patients, when they have septicemia due to the bacteria infection or low blood pressure or too much of salt, they're eating too much of salt, this leads to, or fever, this factors helps to polarize the immune system more to Th17. Fever, low blood pressure, and high salt intake, they have signals, and we're going to explain why high salt intake leads to more polarization to Th17. One of the mechanisms, we're going to explain it down when we talk about the microbiome. But also we find out if the patient is low blood pressure and you have too much of angiotensins and too much of active RAS system, it seems that RAS system, once being active, it signals and it moves the immune system to Th17. And so losartan blocks the angiotensin 1 receptor, blocks the polarization to Th17, and losartan can be used to treat multiple sclerosis. We're using it to treat COVID-19 cytokine storm, but also we can use losartan to treat autoimmune diseases. And with low dose, I can use 5 milligrams sublingual, and I can have some impact on multiple sclerosis inflammation by decreasing the polarization to Th17. Dr. Mike Beamer here, he's taking, I told him about this idea, and now we are thinking to develop sublingual losartan, 5 milligram. And losartan, it does have anti-aging effect as well, because it does help decreasing this inflammation and all those free radicals. It does help the mitochondria as well. Same like methylene blue. Oh, methylene blue. The other thing about methylene blue, it does inhibit the polarization of the immune system to Th17. That's a good news for cytokine storm COVID-19, right? But also it's a good news for treating autoimmune disease or for treating gout. Gout is mediated by overactivity Th17. So I can treat gout with methylene blue and losartan. Oh, the other drug, what we hear about ivermectin. Remember ivermectin? It does help to manage COVID-19 cytokine storm because ivermectin is a Th17 blocker. It inhibits the signaling and the polarization of the immune system to Th17. All this is good news, right? So now I can use ivermectin, I can use methylene blue, I can use losartan. What are the things I can use to manage multiple sclerosis? We know that because of inflammation and gliosis in the brain leads to sympathetic overactivity. Sympathetic leads to release of norepinephrine in the gut, stimulating NOx enzyme, generating free radicals, inflammation in the gut, right? Because of that. See the redox language here is involved with immunological. And what happened here? And metabolic, we're going to see the metabolic codes as well. Inflammation in the gut, breaking the barrier, allowing the toxins to go into the blood, into the brain, aggravating the gliosis. So if we manage the leaky gut syndrome, we can minimize the gliosis, the inflammation of the brain. So management of leaky gut syndrome is management of multiple sclerosis. Now we start talking about integrative metabolic, right? What about vitamin D? Vitamin D also inhibits the polarization of the Th17. So it's a Th17 blocker. So people with deficiency of vitamin D, they have too much of polarization to Th17, right? So giving them vitamin D. Sex hormone, especially estradiol, it does help to decrease interleukin 6. It is interleukin 17 blocker. So regulate the immune system, restore the sex hormone level. See, I'm talking now metabolic, integrative medicine, redox medicine at the same time. Okay, what about the diet? Yes, if you have low sugar, low carbohydrate, we know the sugar, it's a free radical generator, right? Taking too much of sugar, 5% of that sugar turns into glycans, turns into free radical generator. They oxidize and turn into bad sugar, right? And this will aggravate the inflammation because they become free radical generators. So low carbohydrate will help those patients because it will decrease the inflammation in general, whether it's Th1 or Th17 response. It decreases the insulin, right? Insulin is a free radical generator. So you don't want too much of insulin.
Salt, too much of salt can damage your microbiome, especially the lactobacillus. And if you damage your microbiome, you will have leaky gut syndrome because you will have the pathogens are growing, let's say the good ones, good bacteria, and that will cause erosions in the barrier, causing leaky gut syndrome. And so low salt intake will help. Polyphenols, flavonoids, in general, curcumin, quercetin, all of those polyphenols that we know, and flavonoids, it does help to inhibit the interleukin-17 signaling in general. So give them polyphenols, give them curcumin, quercetin, ECGC, resveratrol, all of those grape seeds extract, all of this may help. Grapefruit seed extract also can help in killing those bad bugs they are like prebiotics. Giving the patient probiotics will help to manage the leaky gut syndrome, which will help to manage multiple sclerosis in general. So you need to screen all the free radical generators that will aggravate the Th17 signaling, the inflammatory Th17 signaling. If the patient has toxins in the body, you need to detoxify the body. If the patient is taking drugs that affect the metabolism and generate free radicals, you need to look at that drug and see how you can wean them or change it. Look for any supplement deficiency, especially when they are having oxidative stress because of this inflammation. They use too much of the amino acids. So you may consider giving essential amino acid to those patients to replenish what they lost from combating and fighting this autoimmune disease. So holistic strategies involve simply changing the patient diets or modulating the microbiota to dampen the Th17 mediated disease, also using biologics. Yeah, I can use PRP. I load the PRP, take PRP, extract it, put it inside the sterile vial. Then I put in the sonication, but I will put NAC, N-acetylcysteine, which still, I can put thymosin beta in it, and vitamin B12, sonicate it, break it down, load it inside those vesicles, because platelets is just a bag with many little bags of exosomes. So you break them when you're doing the sonications, and you load them inside those little exosomes, you nanofiltrate, and you can give it intranasal. With those platelets growth factors and anti-inflammatory and antioxidants and NAC that you add, you can add methylene blue, right, as well. You can add B12 and inhale it or intranasal it, simply just 1-2 mil intranasal it every other day. It may help to decrease the inflammation, the gliosis, and block the Th17 signaling. Or simply, if United States are low, especially under IRB, you can go ahead with stem cells as well. Break them down into exosomes, intranasal it. This helps to modulate the nitrate redox environment. And that's what we're doing, right? As integrative doctors or as a chronic disease prevention management specialist. So high salt diet has been shown to induce Th17 cells and exacerbate the multiple sclerosis. This, there's a team that's supporting this and how the salt is destroying, killing the good bacteria, the good bugs, right? And when you destroy the good bugs, then the bad bugs will start breaking down the barrier and leaking those toxins. So high salt diet trigger and increase the number of pathogenic Th17 cells in the peripheral blood of the mice. And we know why, right? And correlating with destruction of the lactobacillus. Seems like salt kills those good bacteria. in the gut microbiome. And what would happen when you have too much salt? Yes, you would have hypertension. Also, would have the RAG system will go up too, the RAS system, and leads to hypertension. So repopulating the gut with lactobacillus species, giving them probiotic, was shown to mitigate the severity of the multiple sclerosis and hypertension, right? So we have all this toxin going to the blood, causing gliosis, causing overactivity, sympathetic tone. Sympathetic tone overactivity can stimulate the RAS system as well. And you will have what we call the hypertension thing, high blood pressure. But if you manage the gut and you decrease the toxins, you decrease the sympathetic tone, you're decreasing the RAS system activities, you're decreasing the Th17 signaling, you're decreasing inflammation of the brain, you're helping it all the way, right? So even a healthy person, if you take too much of salt, it can kill those microbiomes, and it can lead to increase in Th17 cells in the healthy human body, according to the studies. But again, we have a bad gut that we know, which is the segmented filamentous bacterium. This is a bad gut. This gut breaks the barrier. We need to get rid from it, right? And when they break the barrier, releasing toxins, prebiotic generator, it will aggravate inflammation, activate the RAS, sympathetic tone, and polarize the immune system Th17, aggravate inflammation of the brain. So we need to get rid from it. How we do that? Just by low salt diet, or giving probiotics, or giving prebiotics. Honey is a good thing. Honey, low dose, not high dose. They have a lot of probiotics that can kill this bacteria. While probiotics have been shown to reduce this bad bacteria, the SFB, and lessen the pathogenesis of the Th17 and Th1 cells, they're reducing this autoimmune disease if generate. Less clear how altering the salt intake or administration probiotic in human patient could impact the disease outcome. Well, yes, I think we know how, and we explain it how. Regardless, it's now clear that modulating the microbiome can play also a major role in shaping the biology of Th17 Treg axis, right? You decrease the Th17, you decrease the cytokines of Th17, what will happen? You unblock the Treg will start, the immune system will start moving to Treg. Remember that? If you block one, it moves it to other one, right? You decrease the interleukin 17 level, you're decreasing the blockage on Treg, and Treg will start polarizing, or your T lymphocytes start polarizing Tregs. You will have more police. That's what we need, right? Okay, I think we finished today. It was a long lecture. I don't know if I made people sleepy here, but if you have any questions, please ask.
Dr. William, are you there? Hello?
Yes.
Okay, so do you have any questions?
Anybody have any questions?
I think we covered a lot. Everyone's brains fried.
I told Dr. William, tell your people to drink a lot of coffee.
I had the double
I myself, when I was reading it and trying to translate it, I was drinking a lot of coffee to really process it. It takes time, but it's recorded, so it's good, so you can play it again and again. And then I need you doctors to bring your cases and use those language, use those parameters, use those markers, use those cytokines, use those concepts in managing your patients.
Dr. Loss, I have one quick question about the vagus nerve. You did not mention that much, but it appears in, especially this last slide, it shows it's significant. And I know there's certain protocols that can stimulate vagus nerve function. How do you factor that into the whole?
Yeah. So this is very important. And that's the reason why I use autonomic system balance testing to monitor the efficacy of managing autoimmune diseases. So when you have inflammation in the brain, you have gliosis because of the multiple sclerosis. This will release free radicals. The free radicals will consume the nitric oxide. Nitric oxide acts like a brake over the sympathetic activities.
Mhm.
To think about that, you don't have much of nitric oxide in the brain. Your sympathetic tone will go up because what's put brake over sympathetic is the nitric oxide. You have too
Mhm.
much of free radicals from the inflammation. And so sympathetic overactivity all over your body will go up, especially to the gut. So when you have too much of sympathetic, which goes to the vagus nerve, right?
Mhm.
Then the sympathetic will release norepinephrine. Norepinephrine stimulate NOx enzyme, natural oxidase enzyme, which will generate free radicals in the gut. The free radicals will stimulate the inflammation, will aggravate the inflammation in the gut, right? Too much of
Mhm.
redox, when it go up, when you have too much of free radicals, you're irritating the whole white blood cells, you're activating in the gut, and you cause overinflammation. That will cause destruction in the barrier of the gut, causing the toxins of the bacteria, the polysaccharides, to move into the blood, which are free radical generators, going to the brain, aggravating the gliosis, more inflammation, more free radicals, less nitric oxide, more sympathetic tone, going to the vagus, to the gut, and then you have that vicious circle. So what you need to do is to figure out how to manage your autonomic nervous system sympathetic overactivities by buffering the redox. And we have all this nice redox modulators that we talked about in nitro medicine, right? And also you need to manage the gut, probiotics and prebiotics. And that may help to restore the balance. But if the inflammation is ongoing in the gut, even if you try to manage the brain with some cytokine blockers and you're not doing anything in the gut can aggravate the inflammation in the brain. Inflammation in the brain also can lead to brain leakage too, right? The blood-brain barrier will be opened up, at least more of free radicals and free toxins, or those toxins going to the brain, and then you have this vicious circle. It makes sense?
Yeah. Yeah.
Okay. Any questions? So you hear about losartan, sublingual, which Dr. Mike Beamer is producing it now as an anti-aging, and also it's a Th17 blocker, which is good for COVID-19 cytokine storm. In Spain, they are developing losartan inhalation to manage cytokine storm and also to manage post-COVID-19 lung fibrosis.
Did you, do you have any information on that, Mike? Can you send us a little flyer or,
Yeah,
the Cliff Note version?
Absolutely. Yeah.
We can put it on the website for our fans here.
Not Clearfield. Yeah, very inexpensive medication. Very inexpensive.
Can you spell it? I couldn't understand.
Losartan, like
Losartan.
Yeah.
It's angiotensin 2 blocker.
So it's medication.
Angiotensin receptor 1 blocker, sorry. Angiotensin receptor type 1 blocker. There's 2 angiotensin receptor, 1 and 2. The 2 is good. It's the antioxidant one that activate the ACE2 receptor. The angiotensin 1 receptor is the bad one because they block the ACE2 receptor.
It's a very light dose of a pretty common blood pressure medication,
Right.
You just use it sort of like
It's
the way you use
angiotensin receptor blocker, ARB.
Sorry, Dr. Halasa.
Right.
Sometimes you can use a low dose of a medication and get a different effect. And in this case, it seems to be,
Yes, it does have, and it blocks the Th17, and also it has anti-fibrotic effect because the Th17 can lead to fibrosis, right? So you're blocking that signaling using losartan. In fact, if there's an articles there, they are injecting PRP with losartan to treat musculoskeletal disease, musculoskeletal injuries. Like if you have muscular injury and you don't want fibrosis, and you do the PRP and you don't want the fibrosis, you can give a small dose of losartan with PRP. That will help in
musculoskeletal injury, healing the musculoskeletal injuries. But it also helps the mitochondria, so it's a good thing, like McCarran Blvd. It has anti-aging quality. So I will recommend losartan for autoimmune diseases and for cytokine storm for sure. Any questions? It's being recorded.
Yep,
Can you put it
recorded.
in YouTube? You can upload it in YouTube?
I don't know how to do that. You show me how to do it, I'll do it.
You have to have a YouTube channel.
I
But
have,
that's fine. I'm going to present it again in my Thursday night.
okay,
I will record it and put it in YouTube. But if you figure out how to put your video in your website to
we can
serve
put it
your
on the,
network,
we can
doctors,
put it
that'll
on
be
the website, so.
right. So any
Okay.
questions? I know it's tough topic. I know it's required a lot of